One of the most important was the medically assisted death. And I had a thought that the people in the West are contemplating the right to die, and we in Pakistan are still struggling with the concept of the right to live. Mental health burden, there's been a presentation in the morning by Professor Bhatti, and he very elaborately talked about the epidemiology and the treatment of depression. So my talk is not a very exhaustive one. So I'll be touching depression with the perspective of primary care. The mental health burden in Pakistan is huge. These are the WHO figures. 24 million people in Pakistan in need of psychiatric assistance. And there are only 500 to 600 psychiatrists to take care of them. And given the prevalence, somebody has to step up and to fill this gap. Some studies in the West have suggested that 60% of the mental health care occurs in the primary care setting. And 79% of the antidepressant medications are given by healthcare workers who are not trained mental health workers. Family physicians are generally considered to be more accessible, less stigmatized, and more comprehensive. So they make a very good person to go to for mental health care. The first challenge, obviously, in treatment of depression is to diagnose it. May look very simple, but it is not. The studies have suggested that 50% of the diagnoses are missed in the primary care. If you were to listen to the patient, this is it, where you have to be all ears. Listen to the patient, what he's saying to you. The most important of these are the 9 symptoms according to the DSM-4 or DSM-5. The most important are the first 2, a depressed mood and a diminished interest or pleasure in the daily routine activities. And if you can elicit one of these 2, and you just need to look for more evidence. And Professor Bhatti talked about these different symptoms in the morning. If you were here, you be knowing all those. It is important, especially after listening to the talk by Professor Newman, to make sure that you do not miss out the medical diagnosis. There are quite a few conditions which mimic a depressive episode, but they're not actually depressive illness. And most important are anemia, hypothyroidism, and some deficiencies. Very important to rule out the substance abuse. And you also need to make sure that the patient has not had any manic or hypomanic episode in the past, because in that case, even if you're dealing with a depressive episode now, the treatment modalities and strategies would be different. There are certain instruments to help us with the diagnosis. In primary care setting, the first 2, patient health questionnaire, they are very helpful, and they can be administered by a trained nurse or a trained assistant. MADRS and HDRS are generally used for monitoring progress in a patient under treatment, or also in the research. Very important to ask about suicide, and ask suicide screening question. There are 3-4 questions which elicit the intent or plan or the current desire to end life, and it is very important to rule out suicidality in any patient with a depressive episode. This is pretty subjective, this classification, but you need to classify any depressive episode into mild, moderate, or severe, especially on the basis of the functional impairment that it causes. While you're treating depression in the primary care, we have two major options available. One are the psychological options, and for any mild to moderate case, the first thing to offer is a psychological therapy. There are different modalities available in psychological interventions: cognitive therapy, behavioral therapy, cognitive behavioral therapy. Cognitive behavioral therapy is the one which has been favored the most, although there has not been found any difference in response rate to all these different modalities. The pharmacological options are quite a few. They are reserved for moderate to severe cases. The general classification is almost 8 mechanistically different groups and more than 22 compounds to choose from, but I've simplified it into tricyclics, SSRIs, and some others. The tricyclics are very effective medicines. They're they're less expensive, but they are fraught with side effects and safety risks. So this is why they are not generally the drugs of first choice, although they can be used as augmentation or adjuvant therapy. SSRIs are the drugs of first choice because of their safety and tolerability profile. They may be a little more expensive. There are different compounds available, nothing to choose between the different compounds. In different studies, they have been found to be equally effective. There are others like venlafaxine, desvenlafaxine, and vortioxetine. They are generally used alone, but all others listed here, mirtazapine, trazodone, they are generally used as augmentation or adjuvant therapy. START trial is perhaps the largest and the most consequential trial ever conducted in antidepressant medication. And it describes 4 levels. And this gives you a fair guideline how to proceed with the treatment of a patient with depressive illness. At the outset, in this trial, citalopram was used and the dose was enhanced until remission was achieved. If by 6 to 8 weeks the patient failed to achieve remission, the patient was offered the choice of either switching to another medicine or to augment. Patients were involved in the decision making, and that helped developing a good therapeutic alliance, and that also helped with the compliance. Once the patient was switched, it was followed up for another 6 to 8 weeks, and another 20-30% patients were able to achieve remission. Amongst the different options were bupropion, venlafaxine, sertraline to switch to, or to cognitive therapy alone. That means switching means stopping citalopram and switching to the other therapy. They were all either augmented to bupropion or buspirone or with cognitive therapy. And level 2A was only for those who were switched to or who were augmented with cognitive therapy. If the patients were unable to achieve remission with cognitive therapy, the cognitive therapy was stopped and the patient was taken to the level 3, where again the patient was allowed to have that choice of switching to mirtazapine or nortriptyline or to augmenting with lithium or T3 thyroid hormone. The patient again followed for 6 to 8 weeks, and in case of not able to achieving remission, the patient was switched to mirtazapine plus venlafaxine or phenylcypromine. Phenylcypromine is an AMO inhibitor, not used any longer. The results have been very encouraging. 20 to 30% of the patients were able to achieve remission at the level 1 with citalopram. Then another 20 to 30% were able to achieve remission once they were switched or augmented to in the level 2. But then there were only the other patients who were not able to achieve remission by that time. Very few, even after the other 2 treatments, there were very few who were able to do that. These are the likely outcomes. Recurrence is pretty common. 26% of the patients after achieving remission, they recur in the first year. And another like 70% patients, they have a recurrence in 10 years' time, within the 10 years' time. Once a patient is under treatment with pharmacological interventions, the follow-ups need to be very regular in the first 12 weeks. At first week to check with the tolerability, and at 2 and 4 weeks to check for response and compliance, or to switch to other treatments if the remission was not achieved. To avoid recurrence, it is very important to complete the treatment. Target should be to achieve remission. The remission means there are no residual symptoms and the functional status of the patient is restored. So the first episode should be treated for 6 to 9 months after complete remission. And if the patient is having a second episode, then the treatment is to be continued for 1 to 2 years after complete remission. And any subsequent episodes, probably the patient will need maintenance therapy lifelong. You need to be aware of these 2 conditions. I've developed my own mnemonic for this serotonin syndrome. FACT stands for fever, agitation, confusion, and tremors, and which can progress to seizures, coma, and death. And this is a possibility when you're treating somebody with serotonins. And another is discontinuation syndrome. If somebody on serotonin, he or she stops treatment abruptly, or this is something which is likely. And I have a mnemonic for this as well: diet, dizziness, irritability, electric shock sensations, and tearfulness. If you are to be a safe doctor, you need to know your limitations. It's important. And you need to know when you need to refer this patient to a specialist. There are certain situations, especially comorbids, and in case of pregnancy, and when you're dealing with a very young patient. Also, when a patient is very suicidal, there is sometimes a need to hospitalize the patient for risk assessment and to alleviate that risk. Depression being very common, it is important that we screen our patients in our outdoors in primary care. We need to distinguish between bipolar disorder and depression, because this is critical for selecting medication in any depressive episode. The first line treatment for the family physicians for mild depression is psychotherapy and symptom monitoring, watchful waiting. Antidepressant drugs have been shown to have a favorable benefit-risk profile in moderate to severe depression, and that is why they are the drugs of first choice. The choice of treatment depends on associated side effects, the presence of coexisting conditions, specific symptoms, and the patient's history of response. Somebody who responded well to any product, any drug in previous episodes is very likely to do so in the current episode and the subsequent ones. And the treatment must not be stopped abruptly. I leave you with this thought, and thank you very much for your patient listening.